So a very good afternoon to all the participants who have shown interest to join this webinar. So every year the CLSI gets updated, and it gives a element of responsibility for each of the microbiologists to update themselves so that the latest guideline they can implement in their antimicrobial susceptibility testing. So last year we had this session where CLSI 2023 was updated by our team, and this year also we have thought that there are some important changes which each and every institute should implement immediately. So at the outset, I would like to thank to IVAR team, uh, specifically to Mr. Patrick and Mr. Bernard, who have shown interest to provide us to give the platform where this webinar can be hosted. So Patrick, a big thank to you and your team. Patrick, am I audible, Ketan?
Yes, sir, you're audible.
Yes, doctor, you are audible.
So Patrick, a very big thank to you and your team to give us the platform to host this event. I'm also thankful to the coordinators who have shown their interest to coordinate with the various participants, especially Stressy. And of course, I would like to introduce my team. So I am Dr. Apurba Sastry, working as Investment Officer and Additional Professor of Microbiology at JIPMER, Puducherry. So with me, we have Dr. Ketan Priyadarshi. Ketan, will you introduce yourself?
Good evening, everyone. Myself, Ketan Priyadarshi, and I am currently working as assistant professor in microbiology at AIIMS Patna. And I have been part of JIPMER for 2 years. I did my postdoctoral fellowship in hospital infection control under Sir. So that's how I'm associated with Sir.
Yeah, and me, Ketan, were involved in drafting the antimicrobial stewardship book, and where our other team members like Dr. Sarumathi and Dr. Deepasti have helped us. So there is a chapter in the book, chapter number 11, which is based on the CLSI and UCAS guideline. But the book is a year old, therefore 23 updates and 24 updates are not available at this time point, because the book released to the market in 23 January. So two CLSI's updates are not been incorporated. That is all the more important reason why we thought we will take this session, so that the readers can update themselves and they can implement in the laboratory. So with Ketan, I have my another student, Dr. Sarumathi, who is sitting next to me. Dr. Charu, can you introduce yourself?
Good afternoon all. I am Dr. Sarumathi. I am currently working as a senior resident and I am doing fellowship in hospital infection control also. I did from post-graduation from JIPMER and now I am doing fellowship in hospital infection control. Welcome you all to this webinar.
Okay, so we will focus the first slide, Ketan. So CLSI 2024, it was released roughly around 10 days back. And the first thing which came to our mind is what are the updates, and whether the updates are, I mean, major changes, anything is there, or only smaller cosmetic, morphological, physiological changes, or any important change which is which needs to be implemented. So when it came to the market around 10 days back, I can remember the date also. I think it was 5th of March, which when it was implemented, when it was launched, and we got the document on the very same day. And then we were going through. Then we realized that there are 4 to 5 important changes which each and every lab has to implement right from day one. So almost 7-8 days we have completed of implementing CLSI 2024 in our laboratories. And I wish the changes are not so much. I mean, the changes are not so difficult to implement. I'm sure after this meeting, each of you, right from today evening itself, you can start implementing in your lab. The major changes are outlined here. There are some minor changes also, which will be discussed as on when the slides will be passed through. The first and important change is the CLSI has changed the breakpoint table for Salmonella and Shigella. Earlier, the breakpoint table was a part of was a part of enterobacterial itself. The Salmonella and Shigella breakpoints were part of enterobacterial breakpoint table itself. But now in 24, they have separated out into a new breakpoint table. But the good thing is all the breakpoint values are same. So it is I will say it is more a morphological change than an implementable change. There is a small element of anti-myogram implementation. There we will do some changes, which Dr. Ketan will be presenting in his slides for Shigella and Salmonella. The second important change is the direct susceptibility test, which was available earlier for blood culture for enterobacterial and Pseudomonas. Acinetobacter also they have added this time. They have removed the breakpoint, disdiffusion breakpoint from Burkholderia cepacia complex. This is the biggest change of CLSI 2024. For Stenotrophomonas, there are some changes like ceftazidime breakpoint was deleted, and minocycline breakpoint was updated, which also we will show you in the subsequent slide. So the second biggest change in 2024 is linezolid breakpoint for Staphylococcus aureus was revised. There are some minor changes in the anaerobic table. A very good addition for this 2024 is ceftazidime-avibactam aztreonam combination methodology has been defined by CLSI. Earlier we used to follow the ICMR protocol, which was laid down maybe 1.5 years back. So we all were following that, but now the CLSI has its own brought this illusion method, which we will explain you in detail in the subsequent slide. So these are the major changes. The minor changes are there here and there. So those minor changes we will the major changes in detail along with the minor changes we are going to discuss subsequently. So the first half of the presentation Dr. Ketan is going to handle, where he will discuss the breakpoint table specific changes, followed by Dr. Sarumathi will take over and she will be presenting the special methods. What are the changes, dosage table changes, direct susceptibility testing changes, and so on. Okay, so I request Ketan to take over from me and continue the session.
Yeah, thank you, sir. So before I go into the details of the changes, I would like to draw attention to the tier concept, which was introduced not this year, the last year, 2023 CLSI, the 33rd edition, in which this earlier we used to have a group concept in CLSI where the antibiotics for which breakpoints have been available for various organism groups were grouped into A, B, C, like that. But since last year, that group concept has been removed and a new tire based concept has been introduced. So now we won't discuss the group concept. Let's keep our focus, because CLSI has go away with the group concept. We'll only retain the concept of tire. So how the tires, what is the purpose of making it a tire? Which antibiotics to be tested for that particular organism group, and how to report them. So testing and reporting for setting up the rules. This is tire concept is based on that. So how they have done it? So they have introduced four tires: tire 1, tire 2, tire 3, and tire 4. Four tires are provided. And what is the purpose of tire 1? What is the meaning of tire 1? Tire 1 means that those particular antibiotics which are mentioned as tire 1 must be routinely tested as a primary test and are routinely reported. So testing is routine and reporting is routine. All those are the primary antibiotics. Now after that we have a tire 2. Tire 2 antibiotics are where testing is definitely routine as tire 1 antibiotics, but reporting is not routine. It's always a cascade rule is implemented, which has been set in the institute. The institute is free to set on the cascade rules, and only following the cascade rules it is reported. Like for example, if all the drugs which are mentioned in tire 1 is found to be resistant, then only an antibiotic from tire 2 will be reported. So, and the cascade rules has two concepts. Cascade rules can be inter-group cascade, inter-tire cascade, and as well as intra-tire. So inside a tire, like tire 2 or tire 3, if many antibiotics are there also cascading rule can be implied. If the lower generation, a tire can have lower generation as well as higher generation antibiotic, we can choose to report one and not to report other. Another kind of cascading is inter-tire. Tire 1 is susceptible, don't report tire 2 and tire 3. Report tire 2 only if tire 1 antibiotics are resistant. Report tire 3 only if tire 2 antibiotics are. So these are two types of cascading, what they recommend. Now what about tire 3? Tire 3 can be used as a primary testing, but only if that particular institution has patients, cater to patients which have a high risk of MDROs. So suppose in your institution you get multi-drug resistant organisms very frequently, then the tire 3 the 3 antibiotics are also can be tested, included as your routine primary testing, but the reporting of it is always cascade. Okay, so this is optional. So if you see in most of our Indian scenarios, most of our healthcare facilities have a high preponderance of MDROs. We get too much of MDROs in our, especially gram negatives. So if you consider a Indian healthcare facility scenario, then even tire 3 antibiotics can be added for primary testing. Reporting is always cascading, but testing can be included as a tire. Then the next tire is tire 4, where definitely testing is not primary. When your tire 1, tire 2, tire 3 testing comes resistant, or your clinicians ask for a particular antibiotic, then only you test it and reporting on request. Then we have urine category, which is primary tested for all urinary isolates, but not for other specimens. Then we have others category and investigational drug. These others and investigationals they are specific drug bug combinations which are marked as either investigational or others. What is the meaning of others? The meaning of other is they are antibiotic which are very effective against that particular organism group. They also have well-established breakpoints, but somehow for some reasons they are not tested and reported in United States. So this rule, the others rule, holds true only for US, but it doesn't hold true for us. So an antibiotic which is marked as others, because the breakpoints are established breakpoint, they are not non-established breakpoint. So we can include, if in our hospital those antibiotics are used for clinical uses, we can include them in our testing. Investigationals, where breakpoints are still undergoing investigation, they are not very concrete breakpoint. Breakpoints are available, but there are still trials, clinical studies are going on, and those drugs are not approved by FDA for use in United States. Those are investigational. If a rare case scenario, those drugs are to be tested, we can also do the testing. So this is the tier concept which was introduced last year. Now, when I told you tier 4 agents only on clinicians use, or certain factors that, suppose all the tier 1, tier 2, tier 3 agents either are resistant, or if susceptible but they are unavailable, patient may be having allergy to them. A polymicrobial agent, polymicrobial infection is set in, where one drug can cater to or treat multiple types of organisms. In those special scenarios, epidemiological purposes, like you're using some particular dish for ESBL detection. One common example is testing for ceftazidime and ceftazidime clavulinate, that is indicated for ESBL testing. So if you're including ceftazidime and ceftazidime clavulinate in your testing, which is not for patient reporting, which is for just characterization, epidemiological, or characterizing and isolate as ESBL or not, then all those testing, they are classified as tier 4 agent. And a rough example of it, like let's see a Vitek panel example. Suppose you are doing a gram-negative testing for any enterobacterials, and you've used Vitek 405 as a panel. So in a Vitek 405 tiring, how it can be done? We can keep agents like ceftriaxone, cipro, gentamicin, and cotrimoxazole as tier 1 agent. We can keep cefepime, cefiperazone sulbactam, piperacillin tazobactam, amikacin as tier 2 agent. The carbapenems, meropenem, impenem, atapenem, etc. can be kept as tier 3. TG-cycline colistin can also be kept as tier 3. In gram-negative, what is the example of tier 4 agent? Suppose you got a carbapenem resistant organism, and your center also does ceftazidime, avibactam, and aztreonam synergy testing. So in those cases, suppose your clinician wants to do this synergy testing so that they can give ceftazidime, avibactam, aztreonam as a therapeutic agent for that particular infection. So the this synergy testing can be considered as an example of tier 4 agent done on request. Now we have plenty of tables marked in CLSI. So first and the most important tables are table 1 and 2. So what is table 1? Table 1 series is basically the tier based concept, where the drugs are enlisted. These are the various tables which are available, and basically the drugs in tables is a table 1 series. The drugs are enlisted in the various tiers, which organism group, which tier, which drugs are tier 1, which drugs are tier 2, tier 3. These tables we'll see subsequently. But table 1 series is tiering of the antibiotic for this specific antimicrobial group. What is table 2? Table 2 series is actual breakpoint tables, where all the for various others organism groups like enterobacterials, Salmonella sigilla separately, Pseudomonas, Acinetobacter, Burkholderia, Cinetrophomonas maltophilia, other non-enterobacterials, Staph, Entero, Haemophilus influenzae, Neisseria, Streptococcus pneumoniae, beta hemolytic streptococci, viridin streptococci, Neisseria meningitis, and anaerobes. So for each organism or organism group, we have different tables. Now the point was, earlier in CLSI, it's a basically just a cosmetic change what they have done. Earlier CLSI, the table were not synchronized. So like for example, For Pseudomonas, for example, the tire table was 1C, but the breakpoint table was named as 2B1. So it was not synchronized. This modification they have done, it's a beautification kind of modification, where they have made sure that both the numbers are same. Wherever it is 1B3, it's 2B3. What major change has come is earlier there was no separate breakpoint table, yani table 2 series for Salmonella Shigella. This is brought up this time. Earlier there was no tire based table for Neisseria meningitis. This is time it is brought up. For anaerobes, there's change in the tire based table. Earlier there was separate table for gram negative anaerobes and gram positive anaerobes. Now they have merged it together in one tire based. So this is about table 1 and table 2, how they have displayed. Then we have a drug doses table 2 doses. Like that, there is a additional table where all the doses has been recommended. What doses for each of them will be recommended. This doses table will discuss subsequently. After the table 2 doses, we have table 3. This is how table 3 looks. So table 3 is a test for special testing. All the special tests which are recommended by CLSI, all the such tests are mentioned in table 3. Like testing methodology for ESBL, carba-NP testing for carbaphenamases, MSIM, eSIM testing. Table 3D is a new addition this year. We have a recommendation for synergy testing of Astronam and Ceftazidime avibactam by disc illusion method. That will be discussed subsequently. Then we all know of colistin testing by disc illusion and agar test. Direct disc diffusion from blood culture broth. We have a series of tables with the testing method, the enterobacterials breakpoint, then the Pseudomonas breakpoint, and the recent addition is Acinetobacter breakpoint has for direct distribution for certain drugs are been introduced. Then for gram positive, these all for gram negatives. Then we have certain special test tables for gram positives like beta lactamase testing for Staph aureus, oxacillin screen agar, vancomycin screen agar, ICR testing for gram positives, high level mupirocin resistance testing, and high level aminoglycoside resistance testing. These are table 3 special test methodology. Then we have table 4 and table 5. Table 4 is all about disc diffusion QC. Their recommendations ranges. We have separate table for BLI agent, BLBLI agent, and we have separate table for non-BLBLI agent. And as well as their frequency, troubleshooting, all those encompassed in table 4. Same way, table 5 is all about MIC QC. They have ranges for BLBLI QC organisms, non-BLBLI agent. For others, the MIC QC ranges, then frequency and troubleshooting. So table 3 is about disc diffusion QC, table 4 is about disc diffusion QC, and table 5 is about MIC QC. These are the tables which we use. Then table 6 is about preparation of broth microdilution, how the agent dilution stocks are prepared, how the calculations are made. Those are all included in table 6, 7, and 8. This is followed by appendices where various important informations are mentioned. Like for example, Appendix B contains the list of intrinsically resistant organisms. Appendix C has a list of QC organisms. Appendix E is about the SDD interpretive category, their doses, etc. Appendix F is about epidemiological cutoff value. Appendix Z is a fairly new introduction last year, which has nice information about the molecular assays, whatever the CLSI recommends. Cephalosporin broth preparation is again something which was introduced last year in CLSI. If centers are testing for it, then how iron depleted mulo agar can be used for cephalosporin broth preparation in detail are mentioned. So these are the indices of CLSI is all about. Now coming back to the proper breakpoint discussions. So enterobacterials changes are very minimal. I'll tell you the basic changes what happened. So the most important change what happened is now till last year enterobacterials had Shigella and Salmonella breakpoints just pushed in the same table. Everything has been scrapped off from the table, from the enterobacterials table, and put in a new breakpoint table. This is one major change which happened. Another major change happened is all the doses comments. So we had a comment section here. All the doses comments has been removed from there and put in a separate table in table 2 doses. Along with that, some few comments which have been changed is I told you one table is there where molecular testing of resistance phenotype is there. There, what the recommendation is that Meropenem weberibacterium, they have this I personally believe is a dubious statement because first point is Meropenem weberibacterium you're testing in your setup or not. If you're using it, if you're testing it, in that case, parallelly, you have to do the determination of carbapenemase gene in your setup. Okay, that is testing for a newer BLBLI. You must empower your setup, to test for all the at least those important gene mechanisms for resistance. Like for example, testing for MBLs, common metalobacterylactamases like VIM, IMP, and NDM, OXA48 like for enterobacterials, and KPC. Those 5, because the therapy with that particular newer BLBLI is going to be effective or not is decided by what type of resistance mechanism is present here. The same comment is introduced here. As we all know, if you know about Meropenem weberibacterium, the only carbapenemase gene mechanism against which Meropenem weberibacterium is effective is KPC. Other than KPC, this is neither active against OXA48 like nor effective against MBLs. So you may get, when you test for this either by disc diffusion or MIC, you may get a in vitro susceptible result on testing, but if that organism harbors OXA48 like enzymes or NDMs or MBLs, then that won't be effective. In that case, you have to change the report to resistant. That is the comment that has been added. So basic rule is if you test for newer BLBLI, then you must parallelly do the some mechanism, preferably molecular based test for determining the common 5 type of resistance in the setup. Then only you can do the reporting confidently. This is one message they have pointed out. Same goes for Cefepime. Same comment they have introduced in the same resistant table of resistance mechanism. They tell that if you pick any carbapenemase resistant gene, then in that cases, reporting of Cefepime often is the error which they picked. So Cefepime coming susceptible or in the SDD range with carbapenemase resistant with carbapenemase products producing genes detected. In that case, the Cefepime should not be reported as susceptible and the report should be changed at resistance. So these changes you can do only when you look for resistance mechanism actively. Either and if you don't look for resistance mechanisms, it's difficult to pick. In that cases, if you get a meropenem or carbapenem resistance, don't try to report Cefepime or the other one. Best is to check for the and whether the carbapenemase are produced or not, because carbapenem resistance can be either enzyme based or it can be efflux-PEM based. Efflux-PEM based mono resistance of carbapenem is quite possible. So at least MC-MISIN must be done. Then you can change this report. So this comment also is there. Coming to Salmonella Shigella, separate table is now introduced. Okay, and the drugs earlier what we used to use, we used to have used the same breakpoint table for enterobacterials with certain ones where comment was additionally given that this is this breakpoint is different for Salmonella, this breakpoint is different for Shigella. But now we have a selected list which doesn't have many important antibiotics. I'll tell you what are those various antibiotics which for now is not included in the breakpoint. So testing for those agents cannot be done, cannot be reported. Now we have ampicillin, we have cefotaxime or ceftriaxone as an equivalent agent. They are marked for Salmonella Shigella also. We have carbapenems among beta lactams. Breakpoint wise, there is no change. What breakpoint is existing for enterobacterus, the same breakpoint exists for ampicillin, cefotaxime, ceftriaxone, and carbapenems. Here you can see that we have two breakpoints mentioned, down and up. So the first breakpoint is for cefotaxime, the second breakpoint, the down one, is for ceftriaxone. Same holds for enterobacterus also. Now we have azithromycin. It's also the same table. Up one is for Salmonella typhi. In Salmonella only for typhi, azithromycin should be tested and reported. And the down one is for all the species of Shigella. We have tetracyclines and we have quinolones. Now quinolones, earlier also it was there, but now quinolones have a separate table, has two tables in this table 282 for Salmonella and Shigella. Here where it is mentioned, it is for Salmonella. As you can see, Salmonella has a different breakpoint wise. It's exactly same what was present earlier. It's not a different breakpoint. It's the same breakpoint where disk diffusion as well as MIC breakpoints were available for Cipro, and only MIC breakpoint was available for levofloxacin and ofloxacin. This is for Salmonella. Same way, tafloxacin was also there for Salmonella as a surrogate test. We have a dedicated quinolone table for Shigella. This breakpoint is exactly same as the Enterobacterus breakpoint, general Enterobacterus quinolone breakpoint. Then we have cotrimoxazole, we have chloramphenicol. So this is the list of antibiotics for which testing of Salmonella Shigella can be performed. Now, there are plenty of antibiotics which are now not part of the breakpoint for Salmonella and Shigella. Earlier, we used to use the Enterobacterus breakpoint for extrapolating the Enterobacterus breakpoint for even Salmonella Shigella, and we used to, even if we don't used to report them for patient, but we used to include them in the antibiogram preparation. Now we cannot do that. Like for example, BLIs like amoxiclav, piptas, we cannot include in the antibiogram. It needs to be excluded from antibiogram also. Fourth generation cephalosporin, ceftazidime, cefiprozone sulbactam, astronum, doripenem, colistin, and this was anyway not effective for Salmonella. So these are the drugs which must be removed from your antibiogram for Salmonella and Shigella, because we cannot use Enterobacterus breakpoint and extrapolate it for Salmonella and Shigella. So among beta lactams, you have only ampicillin, ceftriaxone or cefotaxime, and 3 carbapenems. That's it. Okay, so regarding Pseudomonas, this is the tier table. We have tier 1, tier 2, tier 3, and tier 4 agent. Again, I'll tell these tiers can be modified based on institute to institute requirement. Like for example, in the Pseudomonas table, for example, we have piptas mentioned as tier 1 agent. You have cefepime mentioned as tier 1 agent. So in your center, you can decide, both are primary testing. Tier 1, tier 2 are both primary testing. So you can decide to keep piptas or cefepime as tier 1, or you can take a call to move them into tier 2 in your institute. So those modifications in between tier for each institute is totally allowable. Same way, Acinetobacter, this is the table. But the only change what they do in Acinetobacter is now a particular breakpoint is introduced for sulbactam and durlobactam. Earlier, what they have is we had QC ranges for sulbactam, durlobactam, but no clinical breakpoint was available. This time they have newly added this into the Acinetobacter. So if you're for patient treating purpose or for generating your antibiogram, generating it for research purposes, now we can use this clinical breakpoint for this agent. Also for Acinetobacter, direct distribution breakpoint using blood culture broth was introduced, that we'll see subsequently. BCC or Burkholderia cepacia complex undergo a very drastic change. All the disc diffusion breakpoints are scrapped with a general comment that disc diffusion testing for Burkholderia cepacia complex is unreliable. It doesn't relate properly with the reference BMD. So disc diffusion cannot be performed for Burkholderia cepacia complex. Now we only have MIC based testing methodology for Burkholderia cepacia complex. So this is a very yeah.
So, I want to add here that each and every center should ensure that you're not doing disc diffusion for BCC. Okay, so please keep in mind for Burkholderia cepacia complex, henceforth, disc diffusion we are not doing. The only method by which BCC can be tested is by doing MIC. So you have to depend upon an automated systems like Vitek. Okay,
Yes.
Ketan, continue.
Regarding Stenotrophomonas maltophilia, one major change what they did is they go away with ceftazidime. Ceftazidime was one agent which was having MIC based breakpoint for Stenotrophomonas maltophilia, even if disc diffusion was not there, but MIC breakpoint was available for ceftazidime avibactam, and it was used also, reported and used also for purpose. Vitek was not giving the data result for that, but if supplemental testing you are doing, then people used to do the testing and report it. Now ceftazidime has been removed totally from Stenotrophomonas maltophilia, so we cannot do as well as report ceftazidime. This is one major change. Another change is in the comment of antibiotic. So in the last year, they have a comment that levofloxacin should not be used as a monotherapy for treating infection with Stenotrophomonas maltophilia. Now they have introduced the same comment for cotrimoxazole. So cotrimoxazole should also not be used as a monotherapy for treating Stenotrophomonas maltophilia infection. So let's look into dive into the testing then. What all we can test? Usually when we test Stenotrophomonas maltophilia with N406 panel, if you're an automated AST testing system, in those cases, if you're a disc diffusion doing institute, then you have option of levofloxacin, cotrimoxazole, minocycline, and cefiderocol is not used therapeutically, so no need of testing that if you don't use it for. So if you are a disc diffusion using center, then you're left with cotrimoxazole, levofloxacin, and minocycline. These three only. If you're using a automated AST like Vitek or some user, then you have the option of additional option. Chloramphenicol is not part of N406, so you may not be getting chloramphenicol data through an automated AST system. So you will again, even with an automated AST system, you will be left with only these three drugs. Now in these three, the levofloxacin and cotrimoxazole are tier 1 agents. Minocycline is a restricted agent or is a tier 2 agent. So whenever you test for levofloxacin, cotrimoxazole, you always have to include a comment that combination of levofloxacin and cotrimoxazole should be used for treating this kind of infection, because neither levofloxacin nor cotrimoxazole is effective as a monotherapy for treating this kind of infection. So this comment with Stenotrophomonas should be part of your reports. Minocycline also, the breakpoint has been revised. minocycline, the breakpoints earlier till last year was 19 zone as susceptible and 4 or less MIC was susceptible. Now the zones has been revised in a way that now we'll be seeing more of minocycline resistance or intermediate results. Like you see, anything which was 19 or more in disk diffusion, 20 or 21, everything was susceptible earlier. We used to report them as susceptible. Now 20 is clear-cut resistance. Even 21 to 25 ranges, which were earlier susceptible, now they are going to fall in the range of intermediate. So once we start using, we should start immediately using the new breakpoints. And once you start using it, we'll be getting more of intermediate and more of resistant minocycline results, looks like. Same went for MIC also. Now the MIC, susceptible MIC has been dropped significantly. 2 dilutions it was dropped. From 4 it has been dropped to 1. So more of intermediate and more of resistant results will we are expecting to get. Now non-interbacterials, they have a dedicated breakpoint. Nothing has properly changed in that. After this, we have gram-positive tables. So gram-positive also change-wise, we have 2 major changes. One change is for linezolid and one is for tidozolid. So linezolid, the breakpoints has been revised. Okay, how the breakpoint has been revised? It has been made as a more higher breakpoint. Like I explained for minocycline, earlier we had a susceptible breakpoint of 21 for disk diffusion. Now even 22 is resistant, which 21, 22, which earlier used to be susceptible. Now those susceptible results will fall in the resistant category. 23 to 25, which earlier was used to fall in susceptible category, now they'll be falling in the intermediate category. So we have to be more stringent on linezolid testing, and you expect more of intermediate results probably once we start interpreting with the revised breakpoint. On the contrary, the MIC breakpoints are not changed. The MIC breakpoints are still same. So those centers which are testing primarily by automated AST methods, their interpretation is not going to change. But those centers which are doing disk diffusion, they may get a more of intermediate linezolid. So the MIC testing and disk diffusion correlation becomes more important to some extent. Now tidozolid is something which for which disk diffusion breakpoints has been introduced. It has been done for many gram-positive organisms. One important one is for Staphylococcus aureus. Even if it is present in the Staphylococcus group, the breakpoints are not for cons. This is a Staphylococcus aureus specific group. Using a testing of 2 microgram, these are the breakpoints which need to be used. So tidozolid nowadays it is available in Indian hospitals. So if your particular center is having using tidozolid as a therapeutic use, you can start testing it, because disk diffusion breakpoints are also available. So you can procure 2 microgram disk and begin the testing and reporting. Now one more linezolid change what has occurred is initially in the staff we have a comment of linezolid is that compulsory transmitted light reporting. Okay, now that comment has been removed from linezolid. So I believe removing a transmitted light comment from linezolid in this year indicates that linezolid resistance can be, it implies that linezolid resistance can be read in as reflected light, as it was done for all the other drugs for Staphylococcus, because this transmitted light comment has now been deleted from linezolid in Staphylococcus. Enterococcus, again there is no change. Breakpoints are exactly same. This is the tire table which is existing currently. Pneumonia also antibiotic breakpoint wise no change. Only beta hemolytic streptococcus we have introduction of tidozolid. We have disk diffusion as breakpoint introduced. with a 2 microgram disc, but this is only for pyogenes and A galaxy. This is not for other reporting other beta amyloid streptococci like CFG groups. It is only for pyogenes and A galaxy T-dissolved breakpoints. Ketan streptococci, again T-dissolved is introduced. That's the only change which occurred, and this holds true for only one species, that is anginosus. Other than anginosus, T-dissolved cannot be tested. Neisseria meningitis, a totally new breakpoint was earlier also available, but the tire table was not available. Now we have a tire table for Neisseria meningitis. This table is different from Neisseria gonorrhea table. So the tiring of antibiotic for Neisseria gonorrhea and Neisseria meningitis is totally different. What are the tier 1 agents for Neisseria meningitis? Penicillin and third generation cephalosporins. Anaerobes, if you do a testing for anaerobes, now we have a common table. The breakpoints, there is no change has occurred, but the new tire tables flipping the things. If you go into the detail of doing this table with the earlier table, there was no change. Only the merging of two tables. Earlier it was gram negative, gram positive separately. Now they have a merged table for anaerobes. Okay. So this was from my side. Now I'll request Saru to continue on the presentation.
I would like to say that till now, whatever Ketan has presented, the most important change which you all should register in your mind is BCC. You cannot do diffusion. Point number one. The only method to do a BCC is by MIC based test. The minocycline breakpoint has been changed for Stenotrophomonas. So you have to revise your because most of us will have a tendency of reading the plates, and if it is I mean measuring zone diameter, I do not know how many of you are doing. If you are measuring the zone diameter, I do not know how many of you are matching with the susceptible breakpoint, or whether it is more than that or less than that. So please ensure in your lab that whoever is measuring the zone diameter, they should match with the latest minocycline breakpoint of Stenotrophonas. Shigella salmonella, the new breakpoint, they have shifted to a new breakpoint. So Ketan, have you explained on the antibiogram aspect of Shigella salmonella? Which
Yes,
antibiotic? Which antibiotic should not be appearing?
BLBLI is the most important one. Cefepime is another one, which earlier we used to include as an antibiogram. Then now those are the two major ones which cannot be part of the. I will show on the table to them.
Yeah, carbapenems are not a problem. They can produce antibiogram for carbapenem, Shigella salmonella, isn't it?
Yes, yes.
Yeah,
Doripenem is not in the list, but rest all three.
Other three are there. So if either Vitek uses, then amoxiclav and cefoperazine sulbactam, piperacillin tazobactam, these three are out of the list of Shigella salmonella. Usually we don't put Shigella salmonella these antibiotics. Earlier also we were not putting, but earlier when we were doing Vitek, automatically this results used to come. So now if those results will come, you have to suppress them from your patient data. You have to suppress these antibiotics from reporting to the clinicians also, as well as from your antibiogram purpose, because they are not a Shigella salmonella list of antibiotic, because now Shigella salmonella has been shifted to a new break. So
even carbapenems, even if you start testing carbapenems in your because you have a dedicated breakpoint now, don't report it to the clinicians. In rare occasions, when you get an XDR kind of salmonella with ceftriaxone resistance, third generation cephalosporin resistant salmonella, in those cases only carbapenems should be reported to the clinicians, because they have a comment also that it is therapeutically inferior to ceftriaxone.
Yes. So with this, I I'm requesting Dr. Sarumathi to take over the session from Dr. Ketan and to continue with the rest of the changes in CLSI 2024. Stage is yours, sir.
Thank you, sir. Good afternoon, all. I will be sharing the slide now. Dr. Ketan, sir, my slide is visible?
Yes, sir.
Yes, sir. Okay. I will start with the dosage table now. We all should know there is a dosage table mentioned in the CLSI editions, which is available for a longer time. But there is a slight change this time.
Letters are visible?
Yes.
Yeah. Okay, sir.
Under Appendix E, we were having dosage regimen, which is used to establish susceptible. If you have susceptible breakpoint that antibiotic is coming to be susceptible, what will be your dosage? That is already mentioned previous years also, but this year there is a slight change. The dosage tables have been shifted to table number 2, and there is slight modifications also. Like previous year, till previous year, we were having a enterobacterial table like this, only for enterobacterials. As the breakpoint table is separated for Salmonella Shigella, so this table has been changed to enterobacterials excluding Salmonella Shigella, and we have a separate breakpoint table for Salmonella Shigella also. And there is a main change here. Like we all know the cefepime, for the cefepime for enterobacterials, we are having a STD breakpoints. In previous years, if you see, there is this is 2023. We will be having susceptible column separately, STD column separately. If that particular antibiotic is having a susceptible breakpoint, they will be mentioning it here. Okay, but this year onwards, like this, it is changed. Only one column where susceptible and STD is mentioned separately. If you see under cefepime, for S breakpoints, this much is the dosage, and for STD breakpoints, this much is the dosage. Like that, in a single column only, CLSI has given the dosage regimens for the STD antibiotics also. There is a major change here. Cefepime, we are giving STD breakpoints. If STD is actually 4 to 8 micrograms, 4 to 8 micrograms SDD for cefepime, SDD breakpoint for cefepime. So we have if we get susceptible breakpoint means this is the dosage regimen. If we get STD, among that if we get 4 microgram, this is the dosage, and if you get 8 microgram, this is the dosage. Okay, and zone diameter also, like corresponding zone diameter also we have for SDD. But now this is a previous year, but now in 2024 there is a modification in STD breakpoint. It's not in STD breakpoint, in a dosage. All this dosage which is mentioned under STD for 4 micrograms is shifted to susceptible dosage. So now this dosage regimen we don't have. This STD for 4 microgram, we are now, that dosage we are now using it. We have to use for susceptible breakpoint for cefepime. And this you can see here, this is 2024. Susceptible, we have to use 1 gram IV TDS or 2 gram IV BD. Previously, this was under STD dosage regimen for 4 microgram, which is also STD. Okay, and this was under 8 microgram. Now we have only one dosage regimen for 8 like STD breakpoints, that is 2 gram IV TDS, which has to be given over 3 hours. That is also important. Last time, like there is no prolonged infusion was given in the dosage regimen, and now you have to see this has to be, if it is SDD, you have to give it as a prolonged infusion over 3 hours. Okay, that has to be emphasized.
So
this
basically now it has been simplified.
yes.
Earlier it was little more complicated. 3 different doses regimens were there. Now it is been simplified for all SDDs, regardless it is 4 microgram or 8 microgram. For all SDDs, we have a single extended dose, that is 2 gram IV 3 times a day over 3 hours. And if it is susceptible, then we can have either 1 gram 8 hourly or 2 gram or 12 hourly. So it is now simplified and it is easy to deliver. And if you are not reporting doses to the patient, then I would suggest that it is very, very useful if you mention the cefepime doses to the patient report. Ideally, we should add the doses report for every antibiotic for, according to CLSI breakpoint, because CLSI breakpoints are derived only based on a particular doses mentioned in CLSI. CLSI clearly says that if you are writing as susceptible, the meaning is whatever doses we are mentioning in CLSI, if you give that, then the patient will respond. This is the true meaning of susceptible. So ideally speaking, we should mention the antibiotic doses in our AST report for all the antibiotics. If you are not doing, then the minimum antibiotic doses which are must to be informed to the patient report is SDD doses, because SDD, when you are telling that is susceptible dose dependent breakpoint, that time it is our duty to inform to the clinician that what antibiotic dose they have to give. Otherwise, clinicians will be ignorant, and this kind of report will not have any other use to the patient report. Okay, Charu, can you tell other than cefepime, which are the other areas where SDD breakpoint is available?
For piperacillin tazobactam, SDD is available for enterobacterials, but there is no change in that.
No change in doses.
No,
doses remain the same as before, but it is also SDD breakpoint. Enterobacterial, piperacillin tazobactam, and cefepime.
Cefepime for enterobacterials and ceftaroline for Staph aureus, it is there.
But yeah, ceftaroline for Staph aureus also SDD breakpoint is there, but it is, I mean, because we are not testing, so the use of this in India is been limited. Ceftaroline for Staph aureus.
Daptomycin for Enterococcus faecium.
Yeah. Daptomycin E-Faecium, also SDD breakpoint is there. If you are putting, then you have to inform to the patient. All these are the SDD examples where the doses mentioning is must. Piptas also you have to mention the dose. Okay, the SDD dose has to be mentioned in the patient report. I repeatedly telling Piptas and cefepime, when you report for enterobacterial, kindly mention the SDD dose. Otherwise, clinician will be ignorant, and specifically mention that it should be given over 3 hour or 2.5 hour IV infusion. This point has to be mentioned. Otherwise, clinician will not be knowing. And repeatedly we are telling that we have seen also clinically that when you give over an infusion of 2 to 3 hours, beta-lactam drugs especially will work much better when compared to when you give a IV bolus. Okay, over to you, Charles.
Thank you, sir. So those participants who are already microbiologists who are already mentioning this previous year's comment in your reports, kindly change over to this and modify accordingly and give your reports. Next, as the you are all aware that there is a separate dosage table, sorry, breakpoint table is changed for Salmonella and Shigella, separated for Salmonella and Shigella. Dosage table also like separated. So we have Salmonella and Shigella specific dosages that is created this year, and some dosages are added for specific like antibiotic organisms. Like you can see sulbactam, durlobactam breakpoints has been added this year. So correspondingly, its dosage regimen also added in the dosage table. And Stenotrophomonas, this is a new addition this year. Minocycline dosage has been added. And for Staphylococcus aureus, particularly for methicillin sensitive Staphylococcus aureus only, ceftriaxone. If it is methicillin susceptible, you can report the dosage regimens for ceftriaxone. That is also has been added for Staphylococcus aureus this year. These three are the dosage additions this year in CLSI. And there are some few changes which has been done. No dosage changes or no addition of antibiotic, but auritavancin already breakpoint is available only for vancomycin susceptible Enterococcus faecalis. So that has been added into the dosage regimen. So for only vancomycin susceptible Enterococcus faecalis, this dosage regimen has to be given. For Enterococcus faecalis only, this has to be given, and for telavancin also the same. Okay, this has been emphasized this year. So these are the dosage regimen changes. Coming to the next topic, that is direct distribution from positive blood culture broth. Okay, like if the blood culture is flagging to be positive, after seeing the gram strain, you will be putting direct distributions. Okay, this has been introduced in the year 2021 itself, and for that time onwards, like for Enterobacterales and Pseudomonas aeruginosa, it is available. And after 2021, it has been some few antibiotics additions was there. But this year in 2024, a new table has been added for Acinetobacter. So this is very important change this year. So Acinetobacter, we have that distribution table this year, and also few antibiotics also added under Enterobacterales and Pseudomonas aeruginosa that I will be telling this year subsequently. So just I will have a recap on the procedure. Okay, just have a recap on the procedure. Those centers who have not started the distribution from positively flagged blood culture bottle, okay, they can have a look on to it. If the blood culture is flagging to be positive, okay, you will be seeing gram strain. Accordingly, DST to be done within 8 hours. That is the rule. Above 8 hours, you should not do. Ideally, immediately, as early as possible only, you have to do distribution from positively flagged blood culture bottle. So they are recommending within 8 hours. You should not exit 8 hours. Okay. After taking this bottle, you have to invert the bottle 5 to 10 times to thoroughly mix the bottle. Then you have to sterilize the top of the bottle with the alcohol wipe, and you have to allow to dry. Then you have to take 4 drops of blood culture broth using this gauge needle only, 20 gauge needle only you have to use, and you have to deliver 4 drops into the Mullen intent agar plate, MHA plate, and followed by this you have to do a lawn culture, same method how you are doing a lawn culturing for the colony distribution. That method only you have to follow for doing the lawn culture. Then you have to place the disc, and in CLSA they are mentioning the 2 time periods. One is 8 to 10 hours and other one is 16 to 18 hours. Okay, so like corresponding zone diameters also they are giving, and for if the growth is there for 8 to 10 hours, after 8 to 10 hours of incubation, if you are finding the growth in the plate, okay, you have to measure by caliper and you can report. Okay, but if there is no growth even after 10 hours, you have to incubate further for 16 to 18 hours and you have to finally interpret. Okay, this is the procedure. There is no procedure change has been done in this year's CLSI. Okay, but as I told previously, there is a new table for Acinetobacter. This is the table. New table, all these antibiotics are new. This new table is created, and here I have mentioned here the colony distributions breakpoint. The actual Acinetobacter table is there in CLSA. So how it is corresponding with that table that we are going to match now. Okay, for ampicillobactam antibiotic, if you see 8 to 10 hours breakpoint is not given, but 16 to 18 hours. So at 16 to 18 hours only you have to interpret. For that, if you see the colony actual distribution table, so it is the same as this table. Okay, so positive flag.
The values are same.
Values are same. Zone diameters, breakpoints are same as the other table. Okay, there are some changes is there. But if you see ceftazidime antibiotic, 8 to 10 hours is not available, but 16 to 18 hours after incubation for 16 to 18 hours, okay, only this breakpoint you have to use. Okay, more than 17 only you have to use. But the Acinetobacter breakpoint, zone diameter breakpoint table, if you see, the 18 and 15 to 17, so 18 is a susceptible breakpoint and intermediate breakpoint is 15 to 17. But this positive blood culture broth table, it is more than equal to 17 for susceptible and 15 to 16, not 15 to 17. 15 to 17 is the main table. 15 to 16 is for the intermediate table. Okay. So this only you have to use. This breakpoint only you have to use. You should not use the other. And cefepime. Cefepime, if you see this 8 to 10 hours and 16 to 18 hours, there is no change in the breakpoints. Both the breakpoints are same and same as the colony distribution breakpoint also. Okay. Like this, all the antibiotics are there and corresponding 8 to 10 hours breakpoint, if it is available, it is mentioned, and 16 to 18 hours breakpoint also is mentioned in the new table. And also there are few additions in the other tables. Already like till last year Enterobacterial Pseudomonas were there, and this year few additions were there, that is tobramycin antibiotic is added now. But if you see the breakpoint, this breakpoint is same as the Enterobacter actual table. There is no change. Same breakpoint has been used. But this Enterobacterial breakpoint they are giving, but this ciprofloxacin breakpoint, you should not use this for Salmonella. So the direct distribution breakpoint which is given under Enterobacterials, you should not use for Salmonella. Okay, and all other antibiotics like ceftazidime, aztreonam, and tobramycin, you should not use both for Salmonella and Shigella. So if you want to do DST for Salmonella, Shigella, only ampicillin, ceftriaxone, meropenem. For Shigella, you can use ciprofloxacin, but for Salmonella, you should not use this breakpoint for ciprofloxacin, and cotrimoxazole you can use. Okay, and for coming to Pseudomonas aeruginosa table for direct distribution, cefepime is added and tobramycin is added. Cefepime we don't have 8 to 10 hours breakpoint, but 16 to 18 hours is available, which is also same as the colony distribution breakpoints. And tobramycin breakpoint, both 8 to 10 hours, 16 to 18 hours are available. And that is also same as the colony distribution breakpoints. Okay. There is QC recommendation. These two QCs were mentioned up to 2023. Now they have recently added in 2024 the C. coli 35281, which is a BLBLI strain that has to be used along with the other QC strains. Okay, this is the QC strain addition for positive blood culture table. So coming to the next topic, that is reduction of MRSA. All of you may have seen this table. This is a table for phenotypic methods. For the reduction of MRSA, we have different methods like cefoxidin MIC, cefoxidin disc diffusion, oxacillin MIC, oxacillin disc diffusion, oxacillin screen agar. Okay, these are the various methods for reduction of MRSA for different species, whether it can be done or not, which one can be done, which one cannot be done. This table is there for a longer time in CLSI. Okay, this is 2000. I have showed here is a 2023 table. But this year there is a morphological changes in the table. There is no addition anywhere. Okay, just they have rearranged this table. Okay, like distribution they have made it as a separate columns, and under this cefoxidin oxacillin they have made into a separate column for distribution. MIC for cefoxidin oxacillin they have made into a separate column. And oxyacetylene screen are same as the last year only. And additionally, MECA and penicillin binding protein 2A detections. Okay, this has been introduced into the table. Okay, this was there last year, like just as a comment below, but this year it has been included in the table itself. Okay, there is no differences between this and this table. Okay, no addition, deletion, nothing, but there is a slight morphological change only. Okay, this can be referred now. Then coming to the cholesterol broth dissolution, actually this CBDE method is done for cholesterol. Okay, there is no change in this either methodology or procedure, nothing. No change this year, but I wanted to tell this. I have to discuss this before proceeding to the broth dissolution method for ceftazidime avibactam and astrione. Okay, to understand better what is available already, I am going to discuss now. Okay, the following few slides are about cholesterol broth dissolution. That there is no change, just it's a recap only. Okay, so it is a tube dilution method for the organism Enterobacteriales and Pseudomonas aeruginosa only. CBDE is recommended, and one another method is there, that is cholesterol agar test, shortly called CAT. Okay, that is also recommendation is there in cholesterol agar test for cholesterol. Okay, that also can be done. Okay, there is no change in that methodology also. Okay, now if you come to this method, what is the media used? We have to use cation adjusted Muller-Hinton broth. 4 tables each of 10 ml is required, and we have to use 10 micrograms of cholesterol sulfate disc. Okay, and as we have 4 tubes. Okay, this cholesterol disc, okay, which is one, we have to keep 4 Muller-Hinton broth, cation adjusted Muller-Hinton broth. One we have to label it as a growth control, other is 1 microgram, then 2 microgram, 4 microgram, then this 10 microgram of cholesterol disc, 10 microgram of cholesterol disc, we have to put here 1 disc into the first tube, which is labeled as 1 microgram, 2 disc into the second tube, which is labeled as 2 microgram, and like third disc, 3 disc is put into the fourth tube, which is having 4 microgram. Okay, then what will be the suspension used? It is 0.5 McFarland suspension to be made in a sterile cell. It's a Collie suspension method. It has to be used, and I will briefly tell the methodology. Label 4 cation adjusted Muller-Hinton broth 0, 1, 2. 0, 1, 2, 4. You can see the tubes. 4 tubes are there. Okay, we have to label. This is a growth control tubes. This is 1 microgram. This is 2. This is 4 microgram tube. We have to label accordingly. Add the respective disc. That is 1 disc into this, 2 disc, and 3 disc into this. You have to add. You have to vortex these tubes. Allowed to stand it for 30 minutes to 1 hour, but not more than 1 hour at room temperature itself. Okay, then you have to add the inoculum. You have already prepared 0.5 McFarland inoculum. You have to put the inoculum of 50 microliters into these tubes. Inoculum has to be introduced, and before incubation, you have to loosen these caps and keep it for 16 to 20 hours. The interpretation is done by seeing the turbidity. So lowest concentration that completely inhibits the growth is taken as MIC. So in this example, you can see in growth control, 0 microgram growth is there, where no cholesterol disc is there. In 1 microgram, we have growth. In 2 microgram, we don't have growth. So in this case, 2 microgram is our MIC. So it has to be interpreted accordingly, according to our breakpoint table. Intermediate is less than 2 microgram. Resistant is more than equal to 4 microgram. So the same procedure, keep in mind the same as easy as polystyrene broth disc elution, we have to do ceftazidime avibactam and aztreonum broth disc elution method, which is a very important table, very easy to perform. If you have just a disc, you can start performing this method very easily. So why this testing method is introduced? So this is for testing the in vitro activity of combination of like aztreonum and ceftazidime avibactam to get therapeutic management of MDR gram-negative infections. So we have previously ICMR document which was mentioning few methods to do the ceftazidime avibactam aztreonum synergy, whether it is there or not. Okay. Now, but CLSI doesn't have any mention on this till previous years. So now we have CLSI, we can start introducing this method. So what method was previously recommended? Now also it's recommending. What is recommended? Already recommended, that I will summarize here. Just it is a these three methods only. One is a gradient strip stacking method, gradient strip crisscross method, and modified E-strip distribution methods. These methods were recommended by ICMR. Now we have to do this method, we need a aztreonum E-strip also, ceftazidime E-strip also. So you have to take a MHA plate, you have to do a lawn culture of it, and you have to place first aztreonum E-strip, keep it for 10 minutes, and then after 10 minutes you have to remove the aztreonum strip, and over the impression you have to place ceftazidime avibactam E-strip. Okay, and you have to take the measurement finally after incubation time. You have to take the measurement by placing a new aztreonum E-strip by superimposing over the impression area. Okay, like this you have to interpret by using two E-strip methods. So for this we need two E-strip methods. This is known as stacking strip method. So now gradient strip crisscross method. Okay, you have to place the, according to perpendicular strip method, we have to place the aztreonum, ceftazidime avibactam E-strip perpendicular manner, okay, at the intermediate breakpoint of aztreonum. And for adjacent strip method, we have to place the ceftazidime and aztreonum E-strips adjacently. And coming to E-strip distribution method, for this we don't need aztreonum E-strip, only ceftazidime E-strip is needed to perform this method. So you will be saving one E-strip here. So you can see the same MHA lawn culture plate you have to take. Ceftazidime E-strip alone is required, and next to it you have to place the aztreonum disc, okay, at the distance of 15 millimeter. Okay, if you get like this, okay, this is known as inverse design. This is known as inverse design. Okay, this is considered synergy is present. Synergy is present here. Here in second case number C, we can see there is enhancement of zone for ceftazidime E-strip, even though aztreonum is resistant. Okay, this also synergy is there. Okay, in this case, next case, the D and E, if you see, okay, there is aztreonum is resistant, ceftazidime also resistant, and synergy is also not present. Then in this case also we don't have synergy. This method was used in most of the labs till the last year, but now we have more convenient method to be done. That is ceftazidime avibactam aztreonum broth disc elution method. Okay. Okay. What is the method used? Same like tube dilution method. We need two discs here. That is ceftazidime and aztreonum disc. For which organism we have to do? Okay. For enterobacterials we can do, and Stenotrochomonas we can do. Mainly for MBL producing strains, it is recommended. Okay. Metallo-beta-lactamase producing strains, it is recommended. Then what is the media you will use? Same like chlorine broth disk elution method. You will be using this media for this cation adjusted Mullington broth. Okay. Same 4 tubes you have to use, but in this method 5 ml is necessary, is adequate. So in CBDE we were using 10 ml, but here 5 ml is adequate. Okay. And this concentration that we use is ceftazidime avibactam 30/20 microgram you will use, and 30 microgram for aztreonam disc you will be using. Okay. And what will be the strength of this ceftazidime and avibactam, like aztreonam, that will be achieved in each of the tubes. That is, so this micrograms you are putting in 5 ml. So in each tube per ml you will be achieving 6/4 microgram for ceftazidime avibactam. 6 is for ceftazidime, 4 is for avibactam. And aztreonam you will be achieving 6 microgram per ml in each tubes. Okay. Then what is the inoculum strength? Same as the cholesterol broth disk elution, 0.5 McFarlane. By colony suspension method you will be doing. So methodology, label 4 cation adjusted Mullington broth. Okay. 5 ml is necessary as I told. Okay. This is ceftazidime you have to label. Aztreonam, one is ceftazidime avibactam plus aztreonam, and another is your growth control. Okay. Then add the respective disc. Whatever the disc strength is recommended, that you have to add. Here you have to add both the disc, both ceftazidime avibactam and aztreonam disc you have to use. So 2 ceftazidime disc, 2 aztreonam disc you have to be used. You have to use. Okay. You have added respective disc into each of this tube. Growth control you should not ask anything. You should not put anything. And vortex this tube, and same like cholesterol broth disk elution, 30 minutes to 1 hour you can incubate this tubes at the room temperature only, not at the incubator. And then 25 microliter of the inoculum you have to add. In CBDE method you are adding 50 microliter. So here you will be adding 25 microliter only. Okay. And then again you have to vortex these tubes and loosen the cap. The same method as CBDE. You have to loosen the cap and you have to interpret. How to interpret? If any turbidity is there, okay, you have to take it as a growth present. So no growth is means growth there means you have to take it as susceptible, and growth is there means you have to take it as a not susceptible. So in finally how to see this tube ceftazidime avibactam plus aztreonam disc, both the disc you have added now, that tube we have to see if growth is there, synergy is not there. If growth is not there means synergy is there. So you can use the that drug combination for metallo-beta-lactamase producer organism. Okay, before that you have to see this and this also. Okay, this growth is there in this or growth is there in this also you have to see. Okay, if the growth is not there in ceftazidime avibactam tube, that means the organism itself is susceptible to ceftazidime avibactam. Okay, and if growth is there means the organism is resistant, and this is same applicable to aztreonam tube also. Okay, and before all this you have to see the growth control to check for the purity. And what are the QC strains that are recommended for this method? This ceftazidime avibactam aztreonam broth dissolution method. Okay, these are the 4 QC strains that are recommended to be used by CLSI. One is our like routine ATCC 25922 strain, which is known to be negative for carbapinamases. And next is Klebsiella pneumoniae BAA strain 1705. This strain is a KPC and SHV producer, known strain. And next one is Klebsiella pneumoniae BAA 21416. This is an MDM strain, and another is a E. coli AR bank strain. This strain will be showing no synergy. Okay. Now this our routine 25922 strain. As the Astrionum, no growth will be there. It is susceptible. Septacerium also no growth will be there, and this is also taken as susceptible. If you combine also no growth will be there. But in some conditions the growth will be there in this separate in Septacerium myobacterium alone without this previous two. That means you have to take some contamination must have happened. You have to rule out that. If only Septacerium myobacterium and Astrionum tube growth is there, you have to look for some contamination in the tube. Then coming to this strains, how it shows the result. Like Astrionum will be Astrionum tube growth will be there. You can see in this picture. Okay, so it is non-susceptible to Astrionum. Septacerium myobacterium, no growth will be there. So it is susceptible. If you combine both, okay, no growth, we will obtain. So this is synergies there. Okay, Astrionum growth is there. Septacerium myobacterium no growth is there. But if you combine both, okay, you will not get any growth. So synergy is there. So coming to Klebsiella pneumoniae BAA 2146, which is an NDM produces strains. Okay, here Astrionum also non-susceptible, not susceptible. Septacerium also not susceptible. But if you combine both, okay, the tube which is containing both the disc will be showing no growth. This indicates that by combining these drugs, you will be getting synergistic activity. So this combination of antibiotic you can give to the patient. Okay, but if this is QC strain 0348, where this this is a known Septacerium myobacterium synergy not present, Astrionum synergy not present strain. Okay, here all the tubes will be getting the growth. Okay, so synergy is not there. Okay, like this you have to interpret for your test strains also, and this is the interpretation for QC strain that I have mentioned. And this you have to the same picture you can see. This picture is there in CLSI edition only, and the same picture you can see to interpret the test strain also and QC strain also. This is the methodology, and this is the interpretation for QC strains. Okay, now I have completed my part. I am handing over the session to Sir, Dr. Apurba Sir, to wind up.
Okay, so we have seen the changes in the CLSI 2024 update. So to summarize, what what we have learned now is in detail what are the changes are available. Now I will summarize the implementable changes. Like each and every lab, what are the list of changes which can be implementable straight away. First thing is you have to understand that the BCC, the disk diffusion is not available. Therefore, you have to do Vitek or any other MIC based method straight away. Don't put disk diffusion for Burkholderia cepacia complex. It is only for BCC. For pseudomyelin, there is no such update has happened. Pseudomyelin, we can use the MORU guideline for disk diffusion, or we can use UCAS for MIC testing. In CLSI M100 pseudomyelin, very few antibiotics are available. So UCAS or MORU guideline can be used. That is as usual. There is no change in that. But for BCC, you cannot do distribution. You have to do the MIC based testing. In Stenotrophomonas, the septagidine breakpoint is been removed, and breakpoint. So septagidine you cannot report for Stenotrophomonas. Correct. Kindly remember, there is no beta-lactam you can report for Stenotrophomonas other than septagidine till now. But in the current guidelines, septagidine also has been removed. Therefore, do not report any beta-lactam for Stenotrophomonas. And the other bigger changes like Staphylococcus aureus linezolid breakpoint has been revised and has been lowered also. Like if you are looking into the distribution has been increased. Therefore, you may expect some resistance trains in future because the linezolid distribution breakpoint has been increased and MIC breakpoint has been lowered down. So minocycline ceratophrimonas breakpoint also has been revised. So these two you can implement straight away. BCC diffusion not available, only MIC you can implement straight away. Okay. If your lab is doing direct susceptibility test like we do at JIPMA, in such case Acinetobacter breakpoints are available. Therefore, that also can be implementable. Okay. Earlier only enterobacterial and Pseudomonas breakpoints were available in direct susceptibility testing. Now Acinetobacter breakpoint also, the direct susceptibility test breakpoint are also available. Now, so these are the straightforward thing you can straight away implement. CLSI M100 breakpoint table has been changed, but the values are same. Therefore, implementation sake there is nothing much to implement because it is the breakpoint the values remain the same. Then the going forward, if you want to introduce a new technique in your lab, then the wonderful technique what the CLSI has laid down is the broad disk illusion test for ceftazidime avibactam SQM combination. Till now, the only method available was the ICMR recommended method, that is the e-test based method, which is little expensive. So if you want to do this test based upon the disk available, then the broad disk illusion method according to the CLSI you can easily implement in your lab. And apart from that, there are many minor changes like the dosage table has been revised. The tire tables are reorganized according to the order of the breakpoint tables. So these are the cosmetic changes which they have done. And what Charu has already presented in her session is the cefepime dose recommendation. The SDD dose recommendation has also been revised. So it is also a dosage related a change you can straight away implement because there is nothing to do by yourself, only the antibiotic advice has to be changed. So this can be straight away implemented.
One or two QC related changes have come, sir. I'll like to highlight that.
Yeah.
Like for example, if
you want to present something, Ketan, or you can only speak?
Just I'll speak, sir. Maybe
Yeah.
I can't write.
You have something to show?
No.
If you have something to show, then I will escape and I will stop sharing and you can present because this is my last slide.
Okay, maybe I'll show this in the directly PDF.
Yeah, in the PDF you can show. PDF in the CLSI PDF you can open and you can show it.
Yes, I'll do that. So is my screen visible? PDF?
Yeah.
So what I was telling is QC related some changes has been introduced. Okay, so though for those centers which do disk diffusion as a QC, they use disk diffusion as a testing and they put disk diffusion QC. The only important change which has occurred is we have Staph aureus linezolid QC ranges have been modified. I'll let me go to the page. Okay, so this is the change. This is what the change is. Earlier it was in the range of 25 to 32, but now the range has been shifted and it has been made 24 to 30. So this change, if you put the QC for linezolid disc for Staph aureus ATCC isolate, that was this 25923, then you must modify your QC documents and now you start using the zone of 24 to 30 as a range. This is one change. Tizolid also the range has been modified. If you start testing Tizolid now for this diffusion 2 microgram disc, then this range has been changed. Earlier the range was 18 to 24. Now the range has been increased, made it as 19 to 25. So this is disk diffusion, linezolid and tizolid in disk diffusion. In MIC, astronom is something where MIC ranges are tested. So we put astronom is included in Vitec automated AST panel. We often use astronom as a disk. So if you use astronom, you must remember this point that the astronom MIC ranges has changed. Not the disk diffusion, the MIC ranges for astronom now has been modified.
MIC ranges means the QC MIC ranges.
QC MIC ranges, yes. So early, this is the change.
Can you magnify a little bit? Your screen is small. Yeah.
So earlier the range was 0.06 to 0.25. Now it has been increased. It has been made till 0.5. So that is for E. coli ATCC 25922. So this, if you're doing a QC, automated AST QC, or for your Vitec cards and all, then this is something which is important. The third important change, which I'll be telling the last one, is for colistin. So if your center is doing CBD, or your center is doing a disk elution for colistin, your center is doing CAT. So this information is important to you, because earlier, this is the change of what I'm talking of. Earlier, E. coli ATCC also had a MIC range. Now that has been scrapped. So earlier, if you're doing colistin both methods in your setup and you want to verify your results for QC, you can use, you could have used E. coli ATCC as well as Pseudomonas ATCC. Now E. coli ATCC you cannot use. That is removed from the QC ranges, and the range for Pseudomonas has been modified. So earlier the range is much bigger range till 4. Now it has been reduced. It is 0.25 to 2 only. So this is of important piece of information for you. If you put CBD and CAT, either of them in your center, and you have to verify that test using a quality control, then only Pseudomonas ATCC should be used, and make sure that it falls in these range. So these three are the prime important changes what happened. That's it, sir.
Yes. So, Ketan, there are some questions which have been raised. I can see in the chat box. So I will read and you can address the questions, Ketan. The first question is, in a patient, if we want to give ceftazidime avibactam and aztreonam infusion, shall we give simultaneously one after the other, or both antibiotics should be given at the same time with two separate IV cannula?
So basically it's a therapeutic question. I'll like to clarify that there are two doses regime for giving ceftazidime avibactam aztreonam simultaneously. One regime is in which both are given as a TDS doses, 8 hourly. So in that, if you're going for that regime, then ceftazidime avibactam and aztreonam can be given simultaneously, mixed together also, and can be given. There's another regime in which ceftazidime avibactam is given 8 hourly and aztreonam is given 6 hourly. In that case, both should be given separately. There is no interaction between them, so both can be given from the same line.
Yeah, so there is no specific separation is required.
Yes.
So one more question is, I think it is just a minor question, that in the colistin brought this elution test, in the fourth tube, shall we put 3 discs or 4 discs? Charu, can you actually address this question, please?
If it is 4 disc only, the fourth tube we have to put. So first 1 microgram, 2 microgram, and 4 microgram. First tube you have to put 1, second tube you have to put 2, and the third tube you have to put 4. Then one more growth control also will be there. There you should not put any disc. Okay. I am correct, sir? Ketan, sir?
Yes.
No, yes.
The next question is why vancomycin and linezolid is not in the dosage table of enterococcus in CLSI. So my answer to this is this they have not been uh, validated yet. Unlike UCAS, where the doses is available for each and every drug by combination, in CLSI it is upcoming now. Now the doses are available for so much of antibiotics. For few, it is not available, which may come in future. You have anything additional to say, Ketan?
Nah, that is the reason, sir.
Okay. The next question: does the antibiotic levonadifloxacin come under any tier system in CLSI? Ketan, can you address this?
So all those are levonadifloxacin will always be a tier 4 agent. So that is tier 4 or others. CLSI more appropriate it will be others because CLSI they don't use the same breakpoint antibiotic as US FDA approved. So yeah, agreed.
One more question, Ketan. I think the remaining questions are related to like audio not visible, not audible, those kind of questions. So the scientific questions are only this much.
Yes.
So I hope we have done a justice to all your queries. If you have any further queries, then you can always ask us by mail or you can discuss with us in the groups. The video of this particular session, we will make it available over next 24 hours. So once it is available, we will share in the groups, and we'll also try to mail to the participants who have asked for the video. But there are 2000 plus registrations, but only 800 to 800 or so people have joined. So we understand that there are some challenges in the joining. That is why many have struggled. So anyway, we will share the videos so that each and every one of you can take the benefit of the session. Patrick, if you're available, you want to speak few words?
Yes, doctor. So let's. I would like to thank all of you for a very detailed session, and I would also thank all the participants who have been, patiently going through and understanding all the nuances of the CLSI related, changes that have been explained during the course of today's session. So, like you had mentioned, we will make the video available both for the benefit of those who are present today as well as those who possibly couldn't make it today. So we will provide this in the next 24 hours, and the link shall be mailed across to all those people who had registered, doctor.
Yeah. Ketan, two, three more questions are there. If disillusion is recommended for SNATO, colistin?
No.
No.
My answer is no.
No. It's only for two Enterobacterus and Pseudomonas aeruginosa. Even for non-aeruginosa Pseudomonas, it is not recommended.
Okay. Salmonella Shigella table is for blood culture or any other sample?
Everything.
Salmonella Shigella table is for there is a breakpoint table for the colonies, and there is no breakpoint table for direct susceptibility tests. No?
Enterobacter is there, but few antibiotics cannot be used for Salmonella Shigella blood culture.
The enterobacterial DST table of CLSI can be used for Salmonella Shigella also, but for only those antibiotics which are used for Salmonella Shigella.
Yes. Ampicillin, ceftriaxone, those drugs can be applicable.
As of now, the Shigella Salmonella table is only for colonies, not for direct susceptibility test. No.
And for colony, it is for all the specimen. It's not specific. It's all the specific.
So, blood culture, Enterobacter broadly, Enterobacter it is written. Under that, ciprofloxacin breakpoint cannot be used for Salmonella. but can be used for Shigella. Like other like ceftazidime, tobramycin cannot be used for Salmonella, Shigella. Okay, other than the ampicillin, ceftriaxone, cotrimoxazole, those breakpoints can be applicable for Salmonella, Shigella. This is given under enterobacterales for positive blood culture bottles. Yes.
If only colicin in intermediate, if only colicin intermediate in AST list, then how can it be administered?
Dosage table is mentioning that colistin intermediate values. So this dosage has to be administered in CLSI. So the intermediate breakpoint, we can follow that.
Sir, we don't have to remove the disc from any disc elution test. They will remain there in tube only. Is it like that?
Yes. We have to keep the disc as such only. We need not remove the disc from the tubes.
In patient, if you want to give, okay, this question is already been addressed. Okay, that's all from our side. No more questions are there. So we once again are extremely thankful to Mr. Patrick from EVA System and Miss Jessie also. They all have helped us to organize this session, giving us the platform and speaking to the audience. Also to Mrinal, they all have helped us. So Ketan and Charu, I am thankful to you. You have given your valuable time to prepare for the session and make the slides. So Ketan and Charu, you want to speak something? You 2 words.
Saru first.
Charu first.
Thank you so much, sir, for this opportunity. The first time I'm taking this session for last year.
Yeah, in workshop you always take.
I was taking not only updates like gram negative organism, gram positive, specific classes we used to take. DST session also I have taken in the AMS workshop. And this is the first time I'm taking update sessions. So I thank you. I thank sir for this opportunity.
Yeah, CLSI as such in JIPA workshop is a complete one-day event. So in the 5 days of antimicrobial stewardship workshop, CLSI we discuss for one complete day. I mean CLSI M100 I'm talking about. Antibiogram CLSI is another one complete day. So that is where we discuss the general terminology, gram negative, bacilli, GNB specific reporting, GPPC specific reporting, then DST. Each of this QC, each of these topics are dealt in detail. So this particular session was meant only to brief you the updates which you can quickly implement straight away in your lab. So if you want to have a detailed discussion of CLSI, then you are always welcome to physically visit JIPMA to attend the AMS workshop. As of now, we do not have any defined time frame when we will conduct the event. As on when we will come to a decision when we are announcing the workshop. At that time, you are always welcome to apply for the event. So once again, in behalf of JIPMAR, I, Dr. Apurba Sastry, along with my 2 dear students, Ketan and Dr. Sarumathi, we are taking a break from here. All of you. Ketan, you have to speak. Yeah, you have not spoken yet.
No, I just have one word to say. I believe a few of the attendee participants would have implemented the changes, especially the breakpoint changes and QC range changes. If not, then take a pledge that tomorrow onwards you won't be using the already changed or removed or deleted breakpoint. So you must make sure that your next reporting should be with the modified changes of QC as well as clinical breakpoints. Not for a single
I remember that the Biomerio will do the Vitek breakpoint changes only across next 1 month of time. They will get their approval from their head office from Singapore or from France. After that only they will come and they'll do the changes. You have to bang your Biomerio team. You have to ask them to do the changes in your Vitek system. So also other automated systems, because they will not change immediately in their system. but the patients will be the sufferers unless you change, unless you update your breakpoint table. Then you cannot implement this in your lab. If you're following a disk diffusion, of course, you can implement straight away. So implementing of what you have learnt today will give us the greatest happiness of taking the session.
So, doctor, you are aware that whoever is using the IBHAR system will have the breakpoints available from next week itself.
Yeah, correct. So the VMR participating centers, VMR project participating centers, of course, for them the new breakpoints will be available from Monday onwards. In Jipper already we have implemented the same day the CLSI was released. So I am happy and proud to say that for last 10 days, minocycline for stenotrophomonas, linezolid for staph aureus, all this we are using the updated breakpoint. Thanks to Ivar once again. So Ketan, Charu, we can close the session. Patrick.
Yes, doctor.
Yes. So I'm taking it off now. Have a nice day.